So you're able to see my screen, I hope, and I'm going to try and put it on the presentation mode. Now, can one of you confirm with me, or Shamila or anybody else? Are you able to see my PPT? And
Yes, yes, Dr. Philip,
yes,
we can see it.
okay.
Thanks.
So I have labeled this presentation as unusual presentations of metabolic bone disease. I'm sure you see the common variety problems like rickets, osteomalacia, and hyperparathyroidism, both primary and secondary. But I thought I will talk about a few scenarios which are less common. So maybe if you do see such a patient, you should not miss that diagnosis, right? So that's what my hope is, and that we will disseminate this information and knowledge among our colleagues and trainees. I am grateful. This is the Believers Church Medical College Hospital where I work. It's a beautiful Gothic architecture of this medical school, and the hospital where I work, it's in the central part of Kerala in a place called Tiruvalla. So the first patient I'm going to share with you is a patient I did see at the Christian Medical College in Vellore when I was doing my training about 15 years ago. But it had a lot of learning value, and I thought I will share that patient with you. This is not really an elderly patient, but very close to 60 years, 59-year-old primary school teacher who came all the way from a nearby state of Tamil Nadu in India, who came with progressively worsening low back pain involving the lumbar spine, the sacroiliac joints, and the hips, and difficulty in getting up from a squat or climbing stairs over a period of 2 years. When he came to us, he was unable to even walk without any support, and he needed people's help. He mentioned that he was a vegetarian, but did take adequate amount of milk products and had adequate exposure to sunlight. As we know that vitamin D deficiency can occur in vegetarians more than in non-vegetarians because many of the foods don't have vitamin D in the vegetarian foods. There was no history of taking any medicines such as anti-epileptic agents or anti-tuberculous agents. He was moderately built. There were facial scars of previous smallpox many years ago, and he had a lump on his skull, which was there for many, many years, he said, like an osteoma. And also, he had noticed a small lump on his left index finger, which came only in the last 2 years, he mentioned. There was some amount of tenderness over the rib cage. And when he walked, we noticed he had the classical waddling gait, which many people with osteomalacia and proximal myopathy have. Objectively, the power was grade 3 in the proximal muscles of the lower limb and grade 4 power MRC in the upper limb. And his reflexes were normal, and he had a flexor plantar response. So clinically, the diagnosis we made was he has osteomalacia, but his age group was close to 60 years, and this was leading to this proximal myopathy and the waddling gait. The likelihood that it could be a nutritional osteomalacia was there, but less likely, I felt. If you look at the lab investigations, what stands out is the phosphate value. Can you see that? The calcium value is normal. The phosphate is really low, 1.8, and the alkaline phosphatase was elevated, about 436. He had normal renal functions, normal electrolytes, and no evidence of acidosis to suggest an renal tubular dysfunction. However, his TMP-GFR was lower. It is only 1.8, suggesting that he was leaking phosphorus through his urine. His PTH wasn't that elevated, and his vitamin D seemed to be normal. So that suggested that he was probably vitamin D replete. Made us think of conditions other than the nutritional osteomalacia in this particular patient. So with a clinical revised working diagnosis of an acquired hypophosphatemic osteomalacia, we thought of what could be the possible clinical differentials. If he was a young child or a young teenager who came with this, I would have thought of the possibility of genetic causes like X-linked hypophosphatemic osteomalacia. Or could it be a renal tubular dysfunction, but the blood test didn't seem to suggest that? Or a rarer possibility such as tumor-induced osteomalacia was also a differential which I considered, because in situations where the calcium is normal, only the phosphate is extremely low, you must think of hypophosphatemic conditions, and one of them is TIO. This is the photograph of his left index finger, and you can see the proximal phalanx. Can you see that? There's a lump there. This is something which caught our attention, especially because we were looking for some lumps and bumps, anything which could be there. The one on the skull, as I told you, was going for many, many years, but it sounded field levels like an osteoid osteoma. Those days in 2006, we were not able to check the serum FGF23 levels, which is now what I would have done if he had come to us now, because you're thinking of tumor-induced osteomalacia, which secrete a phosphotonin, which is today called as fibroblast growth factor 23. Those levels can be checked these days in specialized labs, but was not available to us then. And we didn't have the gallium dotatate scans as well at that time, which are specific for neuroendocrine lesions. If you were all sitting face to face with me, I would have asked you what this X-ray shows. It's got a very classical finding, and this red big arrow points towards, this is known as a pseudo fracture. There seems to be a break in the cortices. And I was looking along the pubic rami whether there's any evidence of looser zones or milkman fractures, as these are called. And there was only evidence of pseudo fracture. So this confirmed that he has probably got osteomalacia. The bone scan using technetium-99 MDP showed there was multiple uptake of the technetium dye all over the bones. And the initial physician who saw this thought, oh, does he have metastasis? But the important thing is to look at the kidney shadow. Usually in people with severe metabolic bone disease, the kidney shadow won't be very brightly taken up. All the tracer is taken up in the bones. And that's how you can differentiate if it's metabolic bone disease versus a patient with metastasis where the kidney shadow is well seen and they have extensive uptake in the bones. This patient had been reported as having probable metabolic bone disease based on the pattern by the nuclear medicine physician. However, because the initial physician was thinking of malignancy, they had done a chest X-ray that was normal. A basic screen for occult malignancy was done with the abdominal imaging, which was negative. The stool for occult blood was negative. And considering tumor-induced osteomalacia, usually they are hemangiopericytomas, tumors in the paranasal sinuses. We imaged the paranasal sinuses, which was normal on a CT scan. In the mid-2000s, we did not have the gallium DOTA scans. And so at Vellore, we did a blood pool scan using technetium-labeled red blood cells. And if you notice, the red blood pools are, because these are highly vascular tumors which produce phosphotonin, we found that the blood pool scan showed an intense uptake in the same area which was seen on the left index finger. And can you see the pooling of blood RBCs there? That confirmed that he's got a very vascular tumor in the finger, which probably is eluting FGF23, which is causing phosphate leak in the urine, leading to him getting osteomalacia. So initially, we treated him, giving him neutral phosphate, 500 milligrams 4 times a day, and as well as ACT1 alpha hydroxylated vitamin D3, that's calcitriol, twice a day to improve his phosphate levels. And then we said this will only be a temporary treatment. As an interim measure, you will need a surgical excision of the tumor, which is probably the culprit behind why you are having this proximal myopathy and osteomalacia. So the biopsy, he agreed to it, and the biopsy showed a mesenchymal tumor. Under H&E staining and 100x magnification, you can see this mesenchymal tumor on histopathology. Forgive me for the lack of clarity of the picture. This is a bit old. What a joy it was to see this gentleman when he came back after a few months on follow-up. He had improved in his symptoms. We could stop his oral phosphate replacements. And you can't take too much of phosphate also. If you take too much of neutral phosphate, you can get diarrhea, as well as calcitriol. His alkaline phosphatase came by 50% down. Calcium remained normal, but the phosphate rose up from 1.8 to 3.9. And when we calculate the TMP-GFR, the threshold for secretion of phosphate, it had improved from 1.8 to 4. That implied that the phosphaturia had also resolved. So he became off drugs and he was doing very well. And the patient was happy, the doctor was happy as well. So what is oncogenic osteomalacia, tumor-induced osteomalacia? Not a very common condition, I must confess, but a common cause for acquired osteomalacia in adult males. The symptoms are similar to the hereditary phosphate wasting disorders. And we look for a possible tumor, which may be visible, may not be visible. You have to look for it in the head and neck region, especially in the sinuses and in the extremities. This patient had a tumor in the extremity. The sinuses may need to be imaged, as well as we can do a rectal exam, because carcinoma prostate also can present silently with a tumor-induced osteomalacia. That's something which is not uncommon at all. And paranasal sinus and a skeletal survey may help to localize the culprit lesion. And because of the vascular nature of the tumor, in the mid-2000s, we did not have Gallium-DOTA scans. We did a blood pool scan, which today may not be required, and that picked up the diagnosis. And today, with octreotide label scanning, we can get a diagnosis. And almost all these patients have FGF23 elevated, and we can confirm it by nuclear imaging. And the commonest culprits are hemangiopericytomas or CA prostate. If you do not find the tumor, I have a lady now under my follow-up where the tumor was not found for about 5 years. It's only after 6th year of follow-up, the tumor surfaced on the imaging. And so we may have to keep giving calcitriol and oral phosphate salt as a treatment periodically. So that's the first patient I wanted to present to you as a patient who came with osteomalacia, metabolic bone disease, but didn't have nutritional causes, but rather had a tumor which was picked up. And once we removed that benign tumor, her osteomalacia improved and she did well. So it was very gratifying. And I'm sure if you must, when you see people in the older age group, think of tumor-induced osteomalacia also as a cause of metabolic bone disease. If you see phosphates really low, but the calcium is normal, and that's a little unusual. In traditional osteomalacia, the calcium will be low, normal, or low. Phosphate will be low, and the alk phos will be high. Coming to the next patient is a lady who was 78-year-old who came to our emergency room with altered sensorium. She was admitted in one of our metropolitan cities in Kerala called Kochi for hypercalcemia evaluation. And she was found to be really rather sick, and they happened to refer her because she was closer to our hospital. She came to us. But when we saw her in the emergency room, our doctors found that there was a past history that she had already had a thyroid surgery, a right hemithyroidectomy, and there was an attempted surgery for inferior parathyroid adenoma excision, but that surgery was a failure. She was on oral medications, they said, for reducing calcium for about 4 years. We found out later it was actually cinacalcet, and she was a long-standing diabetic. She was having Parkinson's disease for the last 10 years. She had had dementia. She was hypothyroid on medication, and her asthma was poorly controlled. She had so many comorbidities. Clinically, she was disoriented but conscious. Her vital signs were stable. Initial medical management with saline hydration and IV zolitonic acid was successful. And then they kept her on oral cinacalcet from the emergency room, and the calciums gradually came down from 15.6 at admission to 11.8 in within 24 to 48 hours. What next? We should be searching for the cause, right? Why did she get this hypercalcemia? And we already have some clues in history that somebody has already dug around her neck looking for a parathyroid adenoma. Lo and behold, we confirmed that the ultrasound did show a hypoechoic lesions adjacent to the thyroid, which seemed like a parathyroid adenoma. And once she was stable, we got the Sestemi B scanning. That's a parathyroid scintigraphy, which confirmed left-sided lesion concordant with the ultrasound imaging. Today, we also have a 4D CT scan available to confirm a parathyroid lesion. And this particular patient was not very keen for a second surgery. And so we had to think of alternative options. So our radiologist suggested that whether this could be managed by minimally invasive methods. So he requested for a 4D CT to see the access to the tumor. And our 4D CT scan, you can see the yellow arrow pointing to the lesion at anterior to the trachea. And that showed that that was a parathyroid adenoma, and it was easily accessible to the interventional radiologist. So this confirmed that both by concordant imaging on the ultrasound, CT, and nuclear medicine imaging, she had a left inferior parathyroid adenoma, which, however, the surgery was done a few years ago. They had explored for a right inferior, and they had missed the tumor. So the option we had given her, the gold standard treatment, is to offer surgery as a way of treating this problem. We did offer her surgery and a surgical excision of the left inferior parathyroid adenoma, but because they had burnt their fingers in the past in a big institution, they were not keen for surgery. In addition, the anesthetist in the pre-anesthetic evaluation said there were so many comorbidities. She's ASA grade 4. That means very high risk for surgery because of the Parkinson's, the dementia, the diabetes was poorly controlled, and she had other complications. So they were not, the family lived in US, the children, and they were not keen for a surgery. They asked us, do we have any other option? apart from long-term medical therapy, which was not working in her. That is when we did some literature review and we talked to our colleagues in radiology whether we can ablate this gland, parathyroid adenoma, by a minimally invasive technique. And the patient opted for a minimally invasive interventional radiology treatment, mainly because the comorbidities, the risk of anesthesia-related complications was high, and there was a past history of a failed surgery for a parathyroid excision in another institution. And we could do this under local anesthesia. So that was an attractive point for the family and for the team. And they have a faster recovery and a shorter stay in hospital. So we started planning after much multidisciplinary team meetings whether we could offer a radio frequency. We had not done that in our hospital previously for a parathyroid adenoma. So we had a discussion. On the day of the procedure, my colleague Tom George, who's the one seen in this picture, had the patient lie in the typical rose position in the neck. The lady is there, the RFA machine is behind her. And right now, under ultrasound guided imaging, he is going ahead and doing the radio frequency ablation. She was just given a low dose of sedation to calm her down. Otherwise, no anesthesia. Under ultrasound guidance, the adenoma was targeted, and the word which Dr. Tom used to me is, I smoked it out. That's the word he used. So he felt that he was able to put the RFA needle into the tumor and it was ablated in less than 20 seconds. And if you see the reports, they are self-explanatory. The phosphate was low in this patient initially. Post-procedure, it started climbing in 24 hours. The calcium dropped to 9.9. Of course, the initial calcium was 15. With medical treatment, we brought it down to 10 and 11, and then it came down further within 30 minutes to 9.9. The gold standard to know the Miami protocol in the US, by which you know whether you have succeeded in your surgery or by a radio frequency ablation, is the Miami protocol, where if you document that your PTH levels done intraoperatively drops by more than 50%, you're fairly certain you have taken care of the culprit lesion. If it doesn't, that means you have missed the gland, or you may have another supernumerary parathyroid gland. And so this patient's dropped from 321 to 141, less than 50%, and in 24 hours, it dropped further to 54.9. So that gave us the confidence that we have tackled, we have got hold of the culprit. And thereafter, I've been following this patient for the last 2 years, and her calciums and parathyroids have normalized. But that is not enough to treat the numbers, right? We don't treat lab reports. We want to see what happened to the patient. And what happened, she was not only was she discharged on day 2, on first month and second month, her calciums remain normal, PTH remain normal, and you can see the tabular columns beautifully documenting the drop from 321 to 64 to 50, and the calciums remaining normal after 2 months. So it is not a flash in the pan. The best thing is this lady was almost close to wheelchair bound, and she could hardly do her activities of daily living without support of 2 carers. But in the second visit onwards, the family members were abroad, but the carers told me now this lady has started doing many things on her own. Her dementia, her memory has improved, her tremors have improved, and she's started being able to take a shower on her own and even started cooking, which was remarkable. So I wondered, well, what happened to her Parkinsonism? And our neurologist said that we could wean her off the anti-Parkinson's drugs. And when we were quite surprised, we did an MRI of the brain previously before the surgery, and it showed bilateral basal ganglia calcification, which is not very common in hyperparathyroidism. It's more common in hypopara or pseudo-hypoparathyroidism. But somehow this high calcium had led to calcification of the basal ganglia, which had probably led on to a secondary Parkinson's, is the inference we had from the dramatic improvement she had. And now today she's able to walk and come to our outpatient clinic. She's very good in knitting, and she started doing many of her hobbies, and her family was absolutely thrilled to bits. And she never had any hypocalcemia. So the take-home message is that radiofrequency ablation is also an option you can consider in patients who are not good candidates for surgery or who refuse surgery. It leaves no scar, and it's a safe and effective treatment for symptomatic patients who may not be fit for surgery and anesthesia. And patients should be given all options of treatment. And this is something I'm sure many of you in your institutions, if you do have an interventional radiologist, can consider for elderly patients who come with parathyroid adenomas. We know that there are 4 glands, and all of them are normally not seen on ultrasound, but it's very important to accurately image the gland. These are all pictures of the parathyroid adenomas. I'm going to skip the slides, but sestamibi scanning confirms that. And you need to have concordance between ultrasound and sestamibi before you offer any procedure. Surgical treatment, parathyroidectomy, for classical foregland exploration, or if there is very certain that you're having a concordant image, you can go for a focused parathyroidectomy, is the gold standard. But patients who are not able to go for surgery till today, a few years ago, we could only offer them long-term alendronate or cinacalcet as a calcium mimetic agent to keep the PTH level down. But today we have an option for the last few years to offer radiofrequency ablation for people who are unfit for surgery. And even asymptomatic hyperparathyroidism who have got end organ complications, we could offer RFA. RFA is not the only way. We can even offer ethanol ablation or laser ablation like we do for thyroid nodules for patients who refuse surgery. If it's a benign nodule, you can offer alcohol ablation, laser, RFA, or microwave ablation. And all these options are available to interventional radiologists in your team. These are a potpourri of all the publications which are there on RFA being used by other colleagues in Texas, in Korea, and in other parts of the world. And in fact, an Indian publication is the one on the right in the middle. Dr. Abhay Kumar Kapoor and Dr. Anubhav Harish Khandelwal published their data on 10 patients in Delhi who had undergone radiofrequency ablation of parathyroid adenomas, published in the JCEM. And when we compared metabolic ablation, microwave ablation versus parathyroidectomy, in a cohort study done in a Chinese cohort, there was no significant difference in the clinical cure rates between the two groups, is what this particular study said. So those of you who want to borrow this presentation, Dr. Chamila has requested me. I'm happy for you to take this presentation and go through it at leisure at a later point. This is the RFA machine which we used. And it's a very minimally invasive technique. It produces heat and destroys the target tissue. You can either go through a transthyroidal approach as seen in this picture, or you can go through a direct approach where you can avoid the piercing the thyroid gland. You need to be careful how you do it, and you need to have a skilled person to do it. That's how the protocol followed by IR specialists. They check the calcium, phosphorus, and PTH regularly. And this is the happy patient who was now able to walk around, who was brought to me with the help of two carers, and a son flew in from Boston to be with her on the day of discharge. And it was a very happy ending. So these are the two patients I did present at Cleveland, and Dr. Chamila was part of that presentation. But I thought I should present two other patients we had as well, who were similar but yet dissimilar in some ways. And now I'm not talking about an elderly patient. It's a very young lady who actually flew in from Abu Dhabi and Sharjah. She lives in Sharjah but works in Abu Dhabi. She came up to our hospital about a year ago saying that she had a lot of heel pain. And very often when we have heel pain, we think of some calcaneal lesion or a tendo-Achilles inflammation. And she was being given in the Gulf countries treated with analgesics. Her blood routine examination as well as calciums done in a laboratory elsewhere were normal, and the ultrasound done by the orthopedic surgeon had shown some tendinitis. So she was being treated for tendinitis with analgesics. Her uric acid levels were also normal. She remained asymptomatic, and then her pain recurred, and then she went on to some alternative systems of medicine like Ayurveda, and she did get some relief. But however, the pain started increasing and she found it very difficult to go to work. And she flew in from the Gulf to Kerala, where that's her hometown, and she came to our orthopedic surgeons initially. And my orthopedic colleagues treated her with medications and analgesics, and she had some recurrence of pain relief, and then she went back to Sharjah. However, the X-ray done when she came back the second time with the recurrence of pain showed there was a cystic lesion in the right calcaneum. It is not so obvious of the X-ray, but the MRI done showed that. In the calcaneal lesion, if you see these X-rays, you don't see the cystic lesion that clearly, but it was very obvious of the MRI. And the MRI showed a well-defined multiloculated cystic lesion in the anterior half of the calcaneum with fluid levels, about 3 centimeters, 3.5 to 3.8 centimeters. So the clinical diagnosis, the radiological diagnosis, probably it could be an aneurysmal bone cyst, and the orthopedician was convinced. He thought it could be a giant cell tumor, and they offered her surgery. She underwent the surgery in our hospital, and the biopsy came back as a giant cell rich lesion favoring a giant cell tumor with certain areas looking like aneurysmal bone cyst. The patient said that she still continued to have pain after a few weeks of surgery. And she also had pain all over the body. And this orthopedician was worried if it's a malignant giant cell tumor. And he sent her over to our nuclear medicine center for a for a bone scan. There, the nuclear physician saw a picture of a metabolic bone disease and said something is different. It's not looking like a metastasis. I think there is a metabolic bone disease. And he did a repeat calcium. And mind you, there was only one calcium done in the past. The repeat calcium done in the adjacent hospital came as 12.7. Normal is 9 to 11 these units if you're using the same units. And the PTH should be normally less than 45 to 50. 72 is our cutoff. Upper limit is 640. So this was showing a high calcium with a high PTH consistent with primary hyperparathyroidism. And what had misled the orthopedician was that there was an report elsewhere which was normal. So he'd never thought of a primary hyperparathyroidism. And they worked along the lines of giant cell tumor and aneurysmal bone cyst. Surgery was done, but not successful in a sense. The adjacent hospital, they confirmed that the calcium was high, the PTH was high, phosphate was low, and the patient came back to us and was referred to us to endocrinology to plan the way forward. And this is the SESTIMI scan. If you can see that this showing that there is no kidney uptake and the bones are avid for the technetium scan. And this confirmed the metabolic bone disease, which led us to go ahead and image the thyroid and the parathyroid, and that showed very clearly the thyroid gland you can see, but adjacent to that there is a parathyroid lesion. And this was seen on the left side, a parathyroid adenoma. And we confirmed on the DEXA scan, we did a bone mineral density because we do that for many of our postmenopausal women. I'm sure you do it regularly for screening for osteoporosis after 5 to 10 years of menopause without fail. This patient's bone density was done primarily to look whether she has differential osteoporosis. You don't expect a 28-year-old girl to have significant osteoporosis, right? But you notice that she's grossly osteoporotic in her spine and femoral neck, but the forearm, which is cortical bone, is far more affected than the cancellous bone in the femur neck or in the spine. And that confirmed that she had got osteoporosis predominantly in the cortical bones more than the cancellous or the trabecular bone. And this is the bone density picture, which showed that everything is in the red area. And if you look at the actual values, the T-score, they are -5 and -4, the femur neck. And the femur neck also, it went down to as low as -7, which shows extremely low levels. And the SESTIMI scan confirmed that she had actually got a superior parathyroid adenoma. And it is a hypermetabolic lesion, and it was concordant with the imaging seen on ultrasound and the CT. And so we subjected her to a left superior parathyroid adenoma excision at Believers, and her PTH normalized, and she went into a hungry bone syndrome due to the sudden removal of the parathyroid adenoma. The bone is avid for calcium and phosphorus, and the calcium and phosphate dropped. And if you see that on the screen, you can see the calcium dropped significantly up to 7.7. And then we were giving her plenty of calcium as well as 1-alpha hydroxylated vitamin D to treat the hungry bone syndrome. Her PTH crashed after surgery from 481 to 47.8, which showed that we had cured the patient. And her vitamin D being very low, she got a lot of vitamin D replacement as well. So the biopsy confirmed there's a parathyroid adenoma. And this lady has come to me. Actually, she just came 4 days ago and met me in the clinic. She comes for a vacation every year. It's about 2.5 years since we have operated on her. She's doing very well. The bone density has dramatically improved to -1.5 from -7, which shows that the bone is healed. And the reason I presented this patient to you all is not everything which looks like a soap bubble appearance on an X-ray, like a giant cell tumor, may be a giant cell tumor. There could be sometimes some of them which mimic a osteitis fibrosa cystica, which you get in parathyroid excess states. And this patient had a treatable condition known as parathyroid adenoma, which got a GCT-like presentation. I want to close with this last patient. In the next 5 minutes, I'll talk about this 70-year-old lady who was apparently well till about a month ago and came to us last year with reduced appetite, nausea, slurring of speech. Over a month, she had become sort of having altered sensorium, and in a nearby hospital, they evaluated her. Her MRI scan of the brain, CT scans were all normal, and the usual electrolytes showed some mild hyponatremia, and the renal functions were showing mild derangement. The creatinine was about 1.6, 1.7. And when she came to us in the emergency room, she was in altered sensorium. There was a tachycardia, but she was not hypotensive. She had good saturation, and she had a staring look. The GCS was dropped a little bit. Her initial investigation showed she had high counts and elevated CRP, but lo and behold, the calcium which she found when the ER doctor got a fright of his life, they called up the nephrologist and us saying her calcium is 20. And I've never seen a calcium more than 20 in all my life, in many years of practice in endocrinology. And magnesium and potassium was low. Her PTH was sky high, is what they told us, and vitamin D levels were low. And they thought maybe this lady, being an elderly lady coming with hypercalcemia, what do we all think of? We think it must be an internal malignancy with a paraneoplastic manifestation, endocrine manifestation of hypercalcemia, maybe a CA lung. And they had done a chest X-ray, no, nothing was there. A CT of the chest, which was normal, and an X-ray of the pelvis was done to rule out any lytic lesions. They thought, could this be multiple myeloma? And we know that hypercalcemia is one of the presentations, especially a low, poor prognostic feature of multiple myeloma presenting late. But none of them have turned out to be true. If you look at this biochemistry, the calcium was just reported as more than 20. They could not even actually give me the value, whether it's 22 or 24 or 30. The albumin was normal, so that's not as an abnormal due to albumin-related issue. The magnesium was a bit low. The creatinine was high. The PTH was one of the highest I had ever seen. The first value was 2,600. The next was 4,020. And mind you, the normal is up to 70. 18 to 72 is normal. And the vitamin D was low. So she had high calcium with high PTH. Unlike a person with an internal malignancy where you have high calcium and a suppressed PTH, because there is PTH releasing peptide, PTH-RP, which will be predominant. And so the endogenous PTH will be suppressed. That's when you suspect there must be an internal malignancy. But when you see high calciums and high PTH, you wonder whether this could be most probably a primary hyperparathyroidism. The only question is you wonder whether this could be a carcinoma. Though 99% of primary hyperpara is due to adenomas, I wonder if this is the carcinoma. And we made a provisional clinical diagnosis of hypercalcemic crisis due to the primary hyperparathyroidism leading to a metabolic encephalopathy. We treated her with IV saline hydration. The emergency physicians were quick to latch on to the treatment. They gave her zoledronic acid. Even though the creatinine was slightly high, the nephrologist said to go ahead and give it and to use calcitonin injectable preparation as well as cinacalcet. We did want to use denosumab, which is one of the monoclonal antibodies which brings down calcium, but the family had financial constraints. It cost about 20,000 rupees at that time when she came last year. And so they refused. They said they could not afford that treatment. And so we could only use the first three options, though the fourth option can also be considered. The ultrasound confirmed when she stabilized, showed there was a 3-centimeter lesion in the right behind the right lobe of the thyroid, which was probably a parathyroid adenoma. And that's the lesion which is shown on the ultrasound with the arrows. And that's another view of the same. And this elderly lady did not have any evidence of ultrasound abdomen showing nephrocalcinosis or renal stones, which can be sometimes associated because of the hypercalcemia. Her tests were repeated and the calciums were all high. So, but she was not fit to go for a surgery or any procedure. So actually, one of the ways we can handle a very high calcium level, which is dangerously high because they could have complications, is to subject them to hemodialysis. And actually, we contacted our nephrology colleagues, got the calcium down, and gradually, after 24 to 48 hours, the calcium came to the reasonable ranges, and we continued her oral medication, IV medications. And after day 2 of hemodialysis, creatinine and calcium came down to 10.2, and we stopped the calcitonin, and cinacalcet was continued, and she underwent an emergency right focus parathyroidectomy with an end block resection because we want to be sure we're not missing a carcinoma. On 14th of July, she underwent the surgery. Her calciums dropped significantly. PTH dropped from 4,000 to 83 after the surgery. The hungry bone we did anticipate will occur, and that was treated with calcitriol as well as calcium high doses. And this is the serial calcium values from 15th of July to 20th of July. You can see the calcium every day was dropping, but we were able to keep it up, and the phosphate gradually picked up. The vitamin D was also replenished. So the biopsy did come back. There's a sigh of relief we had when we know it is only an adenoma. The Ki-67 index was not elevated, so we knew it is consistent with the parathyroid adenoma. And only thing is a giant parathyroid adenoma coming as a hypercalcemic crisis is a little unusual. And the bone density confirmed that she had differential osteoporosis. Can you see the radius, the bone density is -5, whereas in the lumbar spine and femur, it is only -2.5, -2.3. And that's a happy face of Radha Munima, who was our patient. She was really back. She was clear. She said she didn't even remember what happened when she came to the hospital. She was so confused and disoriented. That's a couple of days before discharge. After the surgery, she did very well, and it was so satisfying to see her go home. And she continues to come on follow-up, and she's doing well. I want to just show you the last two slides that about giant cell tumor and aneurysmal bone cysts. Common orthopedic conditions. Patients may come to the orthopedic clinic or to the geriatric clinic with pain in various parts of the body, but whenever you see an aneurysmal bone cyst or a giant cell tumor, don't forget there could be a medically treatable cause, especially hyperparathyroidism primary. And this particular patient turned out to have a mimic of aneurysmal bone cyst and giant cell tumor. It turned out to be a primary hyperparathyroidism leading to osteitis fibrosa cystica. And primary hyperparathyroidism coming as a hypercalcemic crisis in an elderly patient, again uncommon, but not so rare. The calcium and PTH both going up tells you this is most probably a primary hyperparathyroidism. The mean values in people who came with hypercalcemic crisis was about 727. I think we have topped the charts. We had this patient having nearly 3,000, 4,000. And there's no clear relationship between the calcium levels and the intact PTH levels, whether they will go into crisis or not. I don't think we have a linear correlation, but it's good to know that hypercalcemic crisis can also be due to a benign tumor. So if any of you would ever like to come to Kerala, you're welcome to come to God's own country. And we are right in the heart of Kerala. This is the Believers Church Medical College Hospital, the entrance. And you're welcome to come and visit us and spend some time if you do have the time. So thank you very much. I'm happy to take questions. And if you do have anything, I'm happy to listen to your comments as well. Thank you very much. Over to you, Dr. Shamila.
Thank you very much, Dr. Philip. That was fantastic and very interesting case scenarios. I'm sure all of our trainees benefited from the discussion. And to start off the discussion, I would like to highlight a few things on geriatric aspects because all these patients actually presented with geriatric syndromes like maybe falls or deterioration of functional level or cognitive decline, etc., etc. So all these patients had geriatric syndromes, and I mean, when we teach our students and trainees and postgraduate trainees about this geriatric syndrome, we always tell, look for a reversible cause. I think that was very much highlighted in the scenarios that you discussed, because even at that age, 78-year-old patients with dementia, I mean, anywhere in the world, you would be talking about palliative care or end of life. But still, if you take a good history, you were able to pick up the parathyroid tumor, and she had past history of surgery, hemithyroidectomy, etc. So that highlights the importance of a good history and looking for a reversible cause despite the age. And I think it was rewarding for you all to see this patient's improvement. And because I want to highlight that because there are medical students, there are medicine postgraduate trainees, as well as geriatric trainees. And I would like to thank our Professor of Physiology, Professor Sudarshini Vasalatantri, who has joined. And she has been supporting our center throughout. And she's endocrinology is her interest areas as well. So thank you very much, madam, for joining. And if there are any questions, I please unmute and ask, or type it in the chat box. We would like to discuss, because this is a wonderful opportunity to discuss with Dr. Philip.
Thanks, Shamila. It was very wonderful. And as you highlighted, the usual practice is when a very aged population, you just try to ignore,
Yeah.
and just symptomatic treatment is given. So here, it's very obvious, that proper care and proper, history taking investigations and proper procedures can do marvelous things for our patients. So thank you very much for inviting me, Chamila.
Thank you, Madam.
And
Enjoyed
thank you, Dr. Philip.
Thank you.
Especially paying attention to a patient's history when somebody is pointing to a specific site with pain. I mean, you have to investigate and see. So, if there are any questions, please ask. I think Pramit has mentioned, I think, the diagnosis about your previous case, the tumor-induced osteomalacia. Yeah, you were spot on to detect that. There's a question from Harindu. Thank you, sir, for your amazing lecture. I have a small doubt about the case scenario 3, where the patient had pain relief initially with an antibody treatment.
Actually, I understand. Actually,
Yeah.
what was typed there was antibiotic, but actually
Oh.
that's not. Actually, what happened is this patient was coming to the orthopedician, had continuous tendinitis, was given analgesics, and in fact, the orthopedicians had also given a course of antibiotics, wondering if there is some infection, but that had not really solved the problem. So the patient kept coming back, and the patient was so touched by this. The orthopedician took a lot of effort, even though he gave antibiotics, they kept coming to him again. But finally, I think the diagnosis was wrong. So I don't think the antibiotic did anything, right? We were thinking of tendo-Achilles tendinitis or something like that. But it's very fascinating that this lady actually didn't have a giant cell tumor, which turned out to be actually hyperparathyroidism, right?
Yes. And the X-ray appearance is classic because we give this to in our OSCEs. Yeah, the projected OSCEs for our exams. We use this type of X-ray. So I'm sure the trainees who joined benefited from that discussion. And we'll be sharing the recording with the wider audience because some of the trainees are still in the awards, unable to join, but we'll be sharing this recording. Thank you, Harindhi, for that question. If are there any other questions? If there are no
Actually,
questions,
I was talking to my pathologist whether on a biopsy report they can differentiate between a giant cell tumor, aneurysmal bone cyst, or osteitis fibrosa cystic, otherwise called as brown tumors, right? We call it brown tumor.
yes.
She's very difficult for a pathologist to actually differentiate the three. It's
Mhm.
very, a lot of overlap in the pathology report between these three conditions. So he says we have to finally, based on the clinical presentation, whether it's the flat bones involved, the bones of the extremity, combined with the clinical presentation, all these put together is how we come to a diagnosis. But in this particular patient, I think the fact and another point I want to mention is calcium reports can often go off. Like this patient actually did have a calcium done elsewhere, but that report was not reliable. So a diagnosis of primary hyperpara, which is a near miss, no, it was a misdiagnosis. So repeating a calcium value, we don't go by just one calcium values often when you have a hyperpara. We must repeat it at least once or twice, and especially an albumin corrected value to know the precise calcium result and then to treat accordingly. So I think this particular patient was a near miss. We could have missed the diagnosis. Unfortunately, the nuclear physician, the credit should go to him in the adjacent hospital who saw the picture and ordered a repeat calcium. They didn't just accept the first calcium as right. That's what led to the right sequence of events, and we could help this patient.
Exactly. Thank you so much for sharing these patient stories, and I'm sure it stimulated our trainees and students. And we hope to keep the collaboration going. And I hope one day you would be able to visit Sri Lanka soon, because we'll be having we are having many conferences, and I'm definitely going to invite you. So we hope that you would, accept our invitation and do visit Sri Lanka to share your experiences. Thank you so much. And thank you for all the participants for joining. And thank you very much. Have a pleasant evening. Good night.
Good night. Thank you.
Thank you.